Respected Professor VRV sir, my co-instructors and dear friends, nice to see so many of you. Sometimes halls are, we have more speakers than the people attending. We are happy to see you. My next 10-minute talk would be on papilledema, overview of papilledema. So basically, if you look at papilledema, the disc is something where it is you look into the eye, you can see the vessels and the nerve directly, and only place where you can see directly like this. Why it's called papilla, I do not know. How many of you know? Because those days they used to see the disc in the dead people. In the dead person, the disc will get swollen. That is why it was called papilla. So it's a misnomer by itself. The other terms used are strong papillae and choked disc. And Parson coined the word papilledema, first reported in a brain tumor, and then it was Patton and Holmes who said the main thing is when there is a raised ICT with disc edema, it's called papilledema. So disc edema with raised ICT is the most important thing. Now there are a number of causes like raised intracranial tension because of blockage of ventricular system and so on and so forth. But the most important theory is that of Sogan-Singh-Ire, where axonal transport mechanism is affected. That is the accepted theory for papilledema formation. So etiology for disc edema, it could be ocular causes. It's only disc edema. Acute hypertonia, acute hypotony, CRVO, they are not called papilledema. Orbital causes, space occupying lesions in the apex of the orbit are causes for disc edema. Now all papilledemas are disc edemas, but all disc edemas are not papilledemas. So this is raised ICP, anything, any space occupying inflammation or anything intracranially will cause raised intracranial tension. Cranial oxycephaly like conditions, CSF changes like Landry-Guillain-Barré, pseudotumor cerebri, or now what we call it as benign idiopathic hypertension. Then you have the tumors of the spinal cord. So IIH and all these things are very important today. Now the most important is, apart from that, systemic disease like hypertension is very important. This papilledema is not only vision threatening in later stages, it can be life threatening in grade 4 hypertensive retinopathy, some of the very violent tumors also. So we can get conditions like this where one side you get a papilledema and the other side you don't have. So ICT lower on one side, then it could be one side. Excess of atrophic glial tissue on one side, it could be unilateral. Then you have the normal disc on one side, that's what I said, atrophic side. The most important what we all talk about is the Foster Kennedy syndrome, ipsilateral optic atrophy and contralateral papilledema. This is, apart from that, the triad is there will be an anosmia because of olfactory frontal groove or frontal lobe meningiomas. So this is the triad of Foster Kennedy. Symptoms are basically not much of symptoms like in optic neuritis. It can be symptomless or transient blurrings could be there. Then peripheral field will get constricted later on, not the central field. But sometimes the disc, blind spot enlargement we can elicit. Central centrocec, all this will depend on which part of the nerve is involved in your papilledema. So basically the raised eyes could be due to the cause, primarily headache, nausea, vomiting and all those things. If there is a sixth nerve palsy, diplopia, altered level of consciousness and so forth. So the Cushing triad for ICT is increased systolic blood pressure, bradycardia and abnormal respiratory pattern, which is a clue to raised ICT. Pupil could be dilated, nerve palsy will be the sixth nerve commonly. There are two gradings, Prison's grading, and there is a halo. Now this is the newer one where there is a halo, partially halo, vessels obscured totally or not. So this is clinically we classify them into so many types. The original Hoyt and Beeston is easier, where you say early papilledema when blurring on one side, established papilledema, which is the acute papilledema. Then we talk about the champagne cork appearance or the vintage papilledema, which is chronic, and then the atrophic papilledema. So this is early, you can see blurring on one side, and this is mild hyperemia is there. Supranasally it will start, and mild venous engorgement. This is the early papilledema. If we can diagnose at that point, that will be. Today we have this ultrasound B scan. We can catch ICT, raised ICT and papilledemas, disc edemas with the typical crescent sign. Spontaneous venous pulsations will be absent. So this is a sign where it is absent. So established papilledema, total disc will be hyperemic, blood margin and cup will be totally filled. The retinal veins will be more engorged and peripapillary hemorrhages could be there. Chronic papilledema is called a champagne cork-like, mushrooms like that into the vitreous cavity. It is not that hyperemic, it will be less. Cup is absent, hemorrhages and exudates will become less. This will be the chronic one. Atrophic is there will be blurred margin and atrophy will set in. We need to differentiate. This is also secondary optic atrophy. It could be differentiated from post-neuritic optic atrophy. So this is one atrophic papilledema. So these are the things we need to know. And reverse tapering of vessels will be there in post-neuritic optic atrophy. During papilledema, you can get the choroidal folds and all. Benign, this is the benign ICT, which is bilateral papilledema, raised ICT. The ventricular system should be normal or small in the neuroimaging, normal CSF study. These are the basic aspects of idiopathic intracranial hypertension. So investigations are, we want to know whether there is any functional defect, because papilledema will not affect immediately. So we need to follow them visual acuity with visual fields. Fluorescent angiography, how it will help us, if there is papillitis, it will be a patchy hyperfluorescence, whereas in papilledema, it will be a diffuse hyperfluorescence. And optic neuritis will get central and centrocecal scrotum. There are 4 types of optic neuritis. Central, axial will produce central and centrocecal. Periaxial around similarly, whereas peripheral, when the bile vessel, the peripheral optic neuritis occurs, will get constriction of fields. So transverse, complete optic nerve. Then you have the FFA neuroradiological signs. They are very, very confirmative for any intracranial lesions. And CSF study like in Freund syndrome or something, we need to look at the study, protein count and so on. Very important is the fields will only be affected later. It could be enlargement of blind spot, central or centrocecal scotomas when the optic nerve is definitely becoming atrophic, and peripheral constriction of fields. So this is something like a patient with bilateral disc edema. So she was referred postpartum. You can see disc edema bilaterally. So basically, she's a young girl postpartum. So we saw the disc edema in both eyes. Then CT scan did not reveal much. But then the MRI of this girl showed multiple intracranial cysticercus cysts. Not only that, all over the body, some thousands of cysts. Unfortunately, they could not save her. This is the diffuse hyperfluorescence of fundus fluorescent angiography. Now, as far as management is concerned, we need to treat the primary cause only. So the primary cause is removal of the space occupying lesion if possible. When it is not touchable, then we go in for ventriculo-auricular or ventriculo-peritoneal or so many shunts. So when both of this is not being possible and we see that the function of the optic nerve is getting affected, we need to do a local nerve sheath decompression. It could be an anterior approach, it could be supra-lid, trans-lid. So many approaches are there. So optic nerve sheath decompression will help to avoid further worsening of the optic nerve function. So this is how it is made. On the table, we can see vascular changes following the optic nerve decompression, which is called the de Vickers technique. This is one of the trans-lid approaches. So many approaches are there. Ultimately, we need to know whether it is a pseudopapilledema or pseudopapillitis or whatever, differentiate from all the congenital conditions. But it is important for us to identify papilledema, sometimes to save the life of the patient. So most important for PGs, there are about so many 13, 14 differences between the papillitis and the papilledema. You say normally there are exceptions. Unilateral in papillitis, papilledema, onset is acute. This is insidious, could be insidious. Vision affected early in neuritis and later and so on and so forth. So vitreous haze, anterior vitreous haze could be there, and other things like it is all relative. Though we say more than 3 diopters and less than 3, it is a relative finding. So fields could be, I told you, peripheral constriction in papillitis. It could be centrocecal depending on the nerve. Most importantly, central centrocecal scotomas and blind spot enlargement. Fluorescent, I said, patchy hyperfluorescence versus diffuse hyperfluorescence. One more test which you can write in your exam. Don't tell the examiner, they may not know. If you do a AC tap, in papillitis you will likely to get cells, and papilledema you won't get. So this is a short overview of papilledema. Thank you so much for the opportunity. Thank you, sir.
Thank you, Chandra, very much. Fantastic lecture. But if PGs are there, I will tell you one thing. We have got, when you're asked in exams, papilledema, what's the most important investigation you're supposed to do? Your answer is taking blood pressure, that's all. Afterwards, you can tell whatever you feel like. Understand now? And one more, and the enlargement of blind spot is because of what? They will ask you. Separation of layers of retina from the disc margin and peripapillary retinal detachment. There are two things. Separation of layers of retina from disc margin and there is peripapillary retinal detachment is there. These are the two reasons for your enlargement of blind spot. Now I request Dr. Karthik.
I'd just like to make a comment on what Sir said. If when Karthik is getting ready, I've seen 3 patients, including one of my own employee. We saw frequent change of glasses, near vision, because of the mild edema. Then we diagnosed papilloedema, grade 4 papilloedema. When say grade 3, grade 4 hypertensive retinopathy, that means systemic is involved. And they had a nephropathy and later on went in for neuropathy and we lost the patient within 4 months. So that's what I said. It is life-saving when we diagnose. Sometimes